So, hi everyone, my name is Kate. I think we've had enough time for everyone to kind of join in. And our topic today is inflammatory bowel disease. Um, I run these like case studies, virtual chatting experiences really informally. I'll have the chat open on my screen. Um, Feel free to let me know if like you can't see my screen for any reason, or if you have questions at any time during this. I'm happy to answer any questions. This is just for you and your learning. So feel free to put anything in the chat. And I hope you guys find it interesting. And yeah. So my name is Kate. Well, firstly, I did my bachelor's in science in chemical engineering at Clemson University. I did a minor in psychology there and also like took my pre-med classes and stuff like that. And then I stayed for another year and I did a master's in applied health research at Clemson, which was very similar to the classes that you take for an MPH, a master's in public health. Clemson just doesn't have an MPH at the time I went there, like didn't have that program. But I wanted to take those kinds of classes. So yeah, that's what I did. It really helped me prepare for like doing research and clinical research in med school and beyond. And now I go to NYU Grossman School of Medicine in Manhattan, New York, and I just finished my first year. I'm doing summer research right now, and then I start my clinical rotations actually in August. We are a 1-year preclinical program, so if anyone has questions about like shortened preclinical med schools, feel free to ask me. And yeah, so I'm currently in MS1, I guess still, but about to be in MS2, so. And then I've worked with Motivate MD since I started med school in 2023. I do interview coaching, advising, editing, all that stuff. So, and I think a fun picture I have here, if you can see what I just have some hobbies I like to do here, like rock climbing. I like to make friendship bracelets, and I put my cat on this one because my cat actually has IBD. So I thought it was very fitting that I present on this topic. I adopted her very recently. They told me that she has IBD based on, they do little cat ultrasounds. They don't diagnose IBD the same way that we do. So they don't, like Crohn's disease and ulcerative colitis aren't really things that you diagnose in cats. So she just has IBD. But yeah, I thought that was funny. And yeah, there's me at my white coat ceremony. So yeah, we will continue on. So yeah, this is the session outlines. We'll do a case. We'll discuss the physical exam, differential diagnosis, assessment plan, and then talk through the pathology of disease and anything else that I, find relevant to this disease process. Please fill out the SOAP note through it, do the quiz. If you feel like I haven't covered anything that's on the quiz, feel free to just type in the chat and ask me if I don't fully cover it, because I want to make sure that you guys like fully understand everything that I put on the quiz and all that stuff. Right. And first we will do a little poll. I always like to do these fun polls, so let me just start it really quick. So if y'all just want to fill out the 2 questions of this poll, it's just like a fun question, and then I just want to get a sense of how comfortable you feel with this topic. So I'll give a few minutes to do that. Whoever put Monday as their favorite best day of the week is insane. Okay, so it seems like most people are a little comfortable with the topic of IBD. I feel like some people probably, at least like maybe some of you know someone who has IBD. I know a few people who have this, whether it's ulcerative colitis or Crohn's. You definitely, even if you don't know that they have it, you probably know someone who has this. Yeah. All right, I'm going to end the poll here and I'll show you guys the results. So it looks like most of you make sense and think that Friday and Saturday are the best days of the week. These Monday and Tuesday people, I don't know. But yeah, and it looks like most people are at least a little comfortable with the topic of IBD, and a few people who don't feel comfortable at all, which is great because we're going to talk about it today. Chris likes Mondays, they're like your Fridays. That I don't understand, but to each their own, I guess. All right, let me stop sharing that. All right, we will continue on. Here's the QR code for the soap note. This should be correct. Let me know if it's not, and feel free to follow along as we talk through this IBD case. Oh, you work weekends in EMS. Yeah, that makes more sense. Yeah, if you have a different schedule, I can understand that. All right, so here is our case details. So a 21-year-old female presents with abdominal pain and diarrhea. She admits to always having had a weak stomach, but she felt that something was wrong when she started to lose weight in the past 3 months and was unable to regain the lost weight. She moves her bowels approximately 6 times daily. Occasionally, the urge to move her bowels will awaken her from sleep. She thinks that she has seen blood in her stool a couple of times, but the majority of the time her stool is loose and non-bloody. The diarrhea does not seem to be temporally related, which means like time related, to eating. So the diarrhea is not time related to eating since it did not abate when she fasted for religious observance. She is a college student and has skipped class multiple times in the last month due to her abdominal pain, which she locates to the right lower quadrant of her abdomen. The abdominal pain remains after having a bowel movement. She occasionally has left knee pain, but attributes that to her exercise routine. So if you guys want to type in the chat, tell me what you think is most concerning about this. Like if you could pick a few things in this case that you think you would be most concerned by, what would they be? Blood and stool, weight loss. Yep. Number of bowel movements a day. Yeah, six is a lot of bowel movements in a day. Blood and stool. Not able to regain lost weight. Yeah, for me, I would say the things I'm most concerned about are definitely the blood and stool, but definitely the unintentional weight loss, and also the abdominal pain. I think right lower quadrant abdominal pain is always something that we want to rule out certain things. What's something we always want to rule out with right lower quadrant abdominal pain? Bernie's point for appendicitis. Yep, appendicitis for sure. Great job, guys. All right. So we also have some pertinent negatives for this case. So she also denies fevers, sweats, or chills. She does not feel anorectal pain, nor does she have a sense of urgency or incomplete evacuation when she has a bowel movement. She denies recent travel or sick contacts, and she denies recent antibiotic use. Does anyone know why we ask about recent antibiotic use with diarrhea? Antibiotics can cause diarrhea, but what disease process are we trying to rule out? Specifically with diarrhea related to antibiotic use, not just upset stomach. C. diff. Yep, exactly. C. diff is something we definitely rule out. I actually worked as a medical assistant in gastroenterology before going to medical school, so I definitely saw my fair share of people with C. diff. And C. diff is becoming more transmittable to like the general population. It used to be like you didn't have to worry about getting C. diff unless you were like immunocompromised, but it is becoming a bit more transmissible. So that's definitely something I was worried about working in gastroenterology for sure. Yeah. So as for the rest of the case, past medical history of psoriasis, no relevant past surgical history, just takes topical medications for her psoriasis. No known drug allergies is what, if you see NKDA in charts, it means no known drug allergies. Patient also denies tobacco use, drinks alcohol socially, no illicit drugs. She's a college student, sexually active, but declines to discuss her sexual practices. And family history has a maternal first cousin with inflammatory bowel disease. So, what social history questions, is there anything else that you think is important to ask here? Or do you think we've covered it? It's fine to say, like, I think you've covered everything important. Any supplements? I love that question. Yep. I think today, like these times especially, people are definitely taking a lot of supplements, and sometimes it's good to know because some of those can definitely affect your GI tract. So that's something definitely important to know, like any vitamins as well, stuff like that. Yeah, allergies. We discussed allergies, no known drug allergies. Someone asked, is IBS a genetic condition? Yes, IBS definitely has a genetic component. So we really see it run in families. Oh, sorry, not IBS. I meant IBD. I don't know about IBS being genetic, but we're specifically, I know sometimes it can be confusing when we say IBD versus IBS. So IBD is inflammatory bowel disease, which is what we're talking about today, versus IBS is irritable bowel syndrome, which is a bit different. You don't see any real like changes to the colon in IBS, but you do in IBD. Someone said abnormal dietary habits. Yep, that's a great thing to ask about. Like, are they on a diet perhaps right now? Maybe that could be like a great thing to ask with weight loss is, have you been trying to lose weight? Is always something that's important to ask about. Yeah, so I like that. But I think otherwise we had a pretty thorough social history, so I think we got most of it. So, do we think that the fact that the pain is not related to eating, do we find that important? What do we think could be like, what would be on our differential if it was related to eating? Esophageal tract inflammation. I think you would see different symptoms there, but like dysphagia, stuff like that, that's definitely related to eating with food going down, but that would be kind of those would be different symptoms. But yes, I agree. Yeah, pancreatitis, that is a great one. With pancreatitis, you'd have like pain after eating, so that's really important. Yeah, gastroenteritis, I like that. Celiac, that's another, yes, I like whoever said celiac, that's a great idea. PCOS, I don't know about that one. I don't know if you would have pain related to eating. That's definitely not something that jumps out to me about PCOS. Another big thing is like IBS. IBS is something that you generally see people like and they're mainly just having diarrhea or upset stomach like right after they're eating. That's something that's very common in IBS. GERD, you would have GERD symptoms after eating. Yep. Ulcers. I also like, yeah, pain eating with ulcers. I bet that could be associated. Yeah, I bet you would have pain after eating. I think ulcers are kind of a very constant present pain, so I don't know if necessarily would just be after eating. But I wouldn't like say it couldn't be. My next question is, would you investigate the knee pain further? Do you think it's possibly related to what's going on here? Does anyone have any theories? It's okay if you don't have any theories, but I'll give you a hint and say that it is perhaps related. Was the person who said to rule out appendicitis? I think you might be referring to there is a test that we do with appendicitis where we move the leg, like we bend the leg and kind of move it around to rule out appendicitis, but that wouldn't be you wouldn't be having pain in the leg. You're moving the leg to see if it produces like pain or other symptoms in the abdomen. Weight gain can sometimes cause knee pain. I don't know about weight loss. And I will say, as for right now, I will say it can be related to IBD, but I'll let you guys cook on why you think that is as we go through this, and then I'll tell you later. Any imaging or labs that would be important to consider here? Ultrasound. I like that. Ultrasound could be helpful with this, but it's not like our first line for this. MRI, I don't think would be first line. Yeah, I wouldn't do MRI or ultrasound as the first line for this kind of thing. CT maybe, but again, not first line. CBC, CMP, I'm fine with those. Colonoscopy, yep. That is the best way to diagnose IBD. Yep. All right. All right. What is on your differential besides IBD? Do you have anything else? I have a pretty short differential for this case just because I gave a really specific case in this example, so we are pretty narrowed down. But I'll ask you, is there any one other thing, if you could put one other thing on your differential besides IBD, what would you put on it? And don't, let's say we've already ruled out appendicitis. IBS is a good one, but I don't have it on my differential because the pain, we didn't see things like the blood in the stool doesn't make us think IBS really, and the pain not being related to eating and other things like that makes IBS less likely. Lower GI bleed, I like that. I don't have that on my differential just because I did a pretty short differential for this, just because of all the symptoms that were very related to kind of IBD, but I like that you always do want to rule out like a bleed or something like that when you are seeing blood in the stool. Colorectal cancer, I also really like that one. Yeah, I didn't put that on my differential for this just because I focused in on it, but I would definitely put that on my differential. And that's something that a colonoscopy could also be helpful in diagnosing. Yeah, ulcerative colitis. So that's one form of IBD. With a blockage, you could see overflow diarrhea with a blockage, but you wouldn't have necessarily all of these other symptoms that we're seeing. But yeah, you would have pain and you would have some kind of like overflow diarrhea you can have where it's like kind of blocking and then it's kind of coming around. So I like that. Yeah, Crohn's is the other type of IBD. So yeah, Crohn's and ulcerative colitis are our two big types of IBD. There's a few other ones. There's something called microscopic colitis, but I'm not going to go into that for these purposes. All right. Let's continue on. So I'm going to kind of just talk through when a workup is necessary for just diarrhea in general. So diarrhea is a really common condition that, like, as you know, pre-medical, pre-healthcare students, you're definitely going to see people with diarrhea. And there's kind of diarrhea that we're really worried about and diarrhea that we're less worried about. It can vary, and it's a common condition that varies significantly from one person to another. Clinically, we define diarrhea as having 3 or more loose or liquid bowel movements per day. So it's really important. I know it can be like gross to some people to talk about this stuff, but it's really important with your patients for you to ask them what is the consistency of these stools. That's something that's really important. And working in gastroenterology, you get really comfortable talking about poop. So, and then a workup is recommended when the diarrhea is chronic, which is lasting over 4 weeks. If the diarrhea is severe and significantly impacting the patient's quality of life. And you might ask me, you know, Kate, when do we know if something is actually impacting a patient's quality of life? They will tell you. It will be very obvious to you if something is really impacting someone's quality of life. If they're like, I can't go to work, or like in this case, I think she wasn't going to school because the pain was so bad. Like that is things that impacts quality of life. If the patient is elderly or appears toxic, that's something else that you should be worried about. If there is evidence of colitis, which colitis means inflammation of the colon. And so like IBD has colitis. That's why we see these symptoms of blood in the stool, severe abdominal pain, and sometimes you can see fever. And then typical antidiarrheal medications are ineffective. Does anyone know, like, just for like a medication quiz question, does anyone know like a really common over-the-counter antidiarrheal medication that people take? You can just say like the brand name. Imodium. Yep. Yeah, and someone said smell is also important. Yes, I completely agree, especially for like something like ruling out C. diff. C. diff has a very particular smell. Also like the color of stool. Yeah, smell and color of stool are very important. Like if the stool is white or if a stool is green, that's something really important to narrow down. Okay, acute versus chronic diarrhea. So acute, less than 4 weeks. With acute diarrhea, this is when we're more worried about something infectious, which could be something like C. diff or a GI bug or anything like that. That's something that we're more worried about with acute diarrhea. So I'll go ahead and spoil it and say that's the other thing on my differential for this is an infectious diarrhea. Yeah. And then chronic diarrhea lasts more than 4 weeks and often requires medical evaluation. Approach to diagnosing diarrhea. So you want to identify the type of the diarrhea, and I'll go through what some of the main types of diarrhea are. And then you want to order the correct tests to further narrow down based on that, and then treat based on those results and do targeted treatment for whatever your diagnosis is. So that's kind of the thought process for how we approach these types of diseases. So we're specifically today talking about inflammatory diarrhea. So like my differential and all the things I'm focusing in on today, just for like succinctness, is going to be related to inflammatory diarrhea. So this is so signs of this: frequent small volume stools, presence of blood or mucus in the stool, tenesmus, abdominal pain, fever. Diagnostic markers. We specifically look at these tests called elevated fecal calprotectin and lactoferrin. And then the next thing, common causes. So inflammatory bowel disease is the one that we're talking about today, and that's the most common, like not most common, but that's one of the big causes of inflammatory diarrhea. And through that, you have ulcerative colitis and Crohn's disease. And then infections. These are probably the most common. Salmonella, Shigella, Campylobacter, E. coli, all this scary stuff that you talk about all the time. Yeah, those are the infectious causes of inflammatory diarrhea. And also ischemic colitis. Does anyone know what ischemic colitis means? And yes, you would see an inflammation marker like CRP, and I'll give examples of that in the labs. But the big markers of inflammatory, specifically diarrhea, because CRP can be indicative of other things, but really the big markers of inflammatory diarrhea, which come from stool tests, are elevated fecal calprotectin or lactoferrin. Yeah, ischemia is loss of blood flow, so you can get irritation to the colon due to loss of blood flow. Yeah. Oh, and for anyone who didn't know what tenesmus is, it's like that feeling of like when you need to pass, like have a bowel movement, but nothing's coming out, the thing. Yeah. And then you can also get segmental colitis associated with diverticulosis. So diverticulosis, or you can just get these like kind of big balloon looking things called diverticuli that form on your colon. And yeah, just think of them as big balloons. On their own, they might not necessarily be a problem, but they can cause segmental colitis. They can kind of disrupt the normal functioning of the colon and cause inflammation. And you can also get diverticulitis, which is when they themselves get inflamed. Yeah. So just going to go into a little bit the types of diarrhea. So we're focusing on inflammatory diarrhea today, but there's a bunch of other types that you want to kind of rule out through your clinical judgment and history and things like that. So yeah, we talked about inflammatory diarrhea. This is when inflammation is damaging the GI tract, leading to, decreased absorption of things, causing diarrhea, and increased secretion of fluids because you're not absorbing them and stuff like that. And we already talked about the rest of things with that. For osmotic diarrhea, this is caused by like when things are poorly absorbed in the colon for a multitude of factors, and so instead you're getting like water in the bowel and stuff like that. So a big example of this is lactose intolerance. That's an example of osmotic diarrhea because it's just like you don't have the transporters to be able to absorb the things that you need to absorb, so you have diarrhea. So lactose intolerance isn't actually like an inflammatory diarrhea, it's a different kind. Another fun fact that I love to talk about is osmotic diarrhea that I learned in med school is if you eat a lot of gummy bears, like a lot of gummy bears. I don't know if anyone's tested this, but if you eat a ton of those, I think it's like the cellulose in gummy bears or whatever makes up gummy bears, it's not like absorbable by your colon. And so you get the same effect as like lactose intolerance, as you can't absorb it. So it draws fluid into your bowel and you have diarrhea. So don't eat too many gummy bears. It's my fun fact for that. And then secretory diarrhea is caused by excessive secretion of electrolytes in water into the intestinal lumen. So you can kind of get that with certain tumors, and also specifically cholera causes secretory diarrhea just based on the mechanism of that disease. And then malabsorptive diarrhea, which is caused by impaired absorption of nutrients. This is a bit different than osmotic diarrhea because osmotic diarrhea is like things aren't being absorbed, so they're pulling water, whereas malabsorptive diarrhea is more like the problem of, I honestly don't know the complete difference. I think it's more of the problem of the things that you need aren't being absorbed properly. But the examples of those are like celiac disease, chronic pancreatitis. Those are like malabsorptive diarrheas. And then functional diarrhea. This is when like we don't have an exact cause for what is causing this diarrhea. So it's kind of like we rule out everything else. And then we're left with this. And that the classic one for that is IBS, so irritable bowel syndrome. So yeah, those are the main types of diarrhea. Yeah, and I think the big difference with osmotic versus malabsorptive is like malabsorptive, you're not absorbing the nutrients and things that you need to absorb. Like with pancreatitis and stuff like that. Versus like osmotic diarrhea, think of it as the main problem is like all those solutes are like pulling water in, and that's the main cause. All right. For the physical exam. So this is our physical exam for our patient. So general, no acute distress, appears stated age, thin. We have like our temperature. Temperature looks normal, heart rate looks normal, respiratory rate looks normal, blood pressure looks normal. So our ear, nose, and throat, atraumatic, mucous membranes are moist. And we do have a shallow-based oral ulcer that is noted on the buccal mucosa. So basically just an oral ulcer. Can't talk. Do we think this is important? And if so, why? So the BP is a little soft, but fine. Yeah, this blood pressure is, yeah. I guess you're a little worried about the 60. I think it's okay. Maybe it's because they've lost a lot of fluid. Like a canker sore? Yeah. Yeah, just an oral ulcer. Yeah. Is anyone worried about the oral ulcer? Could indicate something. Yeah, I'll take it. Cardio looks normal, pulmonary looks normal, our abdomen looks like we have normal bowel sounds, soft, but you do have tenderness at the right lower quadrant, no rebound or guarding. Does anyone know what rebound tenderness is? Or what guarding is? Yeah, dehydration would have been the soft. Yeah, I agree. Anyone know what rebound or guarding is? Like, what does that look like on physical exam? Not sure. Pain upon assessment of physical area. Close. So rebound tenderness is actually, have you ever seen someone say, does it hurt more when I push in and then they push in on the area, or when I take it away? Has anyone ever seen that before? So rebound tenderness is actually when it hurts more when you take off the pressure, like right after. So like that rebound pressure, versus just like palpating. Rebound tenderness is when you release the press, you get pain. Yeah. And then guarding, there's involuntary guarding and voluntary guarding. So like voluntary guarding, like when someone presses in, they'll like try to like kind of guard against it. But it seems more voluntary, like they're being like out, and kind of going like that. Involuntary guarding, they're like really can't even help it, like they guard against the pain. And it's just a very involuntary action because it's so painful. So that can just kind of tell you the severity of their pain. Rebound tenderness specifically is when we're more worried about something being inflamed in that area, like peritonitis, like inflammation of the abdominal cavity, or appendicitis. And then the extremities, no clubbing, cyanosis, or edema. So that just means that's normal. And then the skin, we see psoriatic plaques on her elbows and knees bilaterally, because remember, she has psoriasis. All right, so there's a lot of labs. I'll let you guys look over these for a second. I'm just gonna go ahead and tell you what are the most relevant ones here to be looking at. So we see a normal white blood cell count. That's something we want to be looking at. An elevated white blood cell count could indicate like could just indicate like a really inflammatory response, which you could see sometimes in IBD flare-ups, but a normal white blood cell count doesn't rule anything out here. Our hemoglobin is low. Do we think this is related? Yes. Why? Concerning for GI bleed. Yes, I agree, but it also can be related to what's going on here, right? Like to IBD. Because like it is bleeding, basically. You're like it's colitis, so you're seeing blood. So they're losing blood because of the colitis from the IBD, basically. So low hemoglobin, frequently seen in IBD due to chronic blood loss from the inflamed intestinal mucosa. Also because you might not be absorbing enough iron, but just because your colon's not working like it's supposed to, and stuff like that. And then hematocrit. That's again just another indication of anemia. So we also see that that's low. Someone said at least the electrolytes look good with dehydration. Yep, that's something you want to look at to see if you need to hydrate your patient more, but looks like they're doing okay. We see that the CRP is high. Great. So this is relevant because elevated CRP levels are an indicator of inflammation. Commonly used to monitor disease activity in IBD. That's a great kind of tracker to see what's going on with someone's IBD. Higher levels often correlate with a more active disease and like a flare-up. Albumin. We see with this, I think we see a normal albumin. Yep. This is a marker of like nutritional status and inflammation. You can get low levels in IBD, I believe, which could indicate like some malnutrition or some like long-term inflammation. So that's just something that you can look at. With vitamin B12, this is something we also want to look at with IBD. And I think this is low here. Yeah, we see a low vitamin B12. Deficiencies in vitamin B12 can happen with IBD because of malabsorption. So the colon's not working the way it should. And so you get a loss of this vitamin that you need. Specifically, really, this happens a lot in Crohn's disease, just because Crohn's disease affects a larger like portion of the colon and like the small bowel and all that stuff. Because the small intestine is where we absorb, I think, most of our vitamins. So and you only see that in Crohn's disease, which I'll get into. So that's why you see it the most in Crohn's disease. Yeah. And fun fact about vitamin B12 is a lack of vitamin B12 can also cause anemia, specifically, I think, a macrocytic anemia, which means big blood cells. That's just macrocytic versus microcytic, and all those things are just ways of identifying different types of anemia to kind of pinpoint what's causing them, basically. Anyway, tangent. The last thing that we're looking at here is the tissue transglutaminase, or the TTG IgA antibody. Here we see that this is negative and we have a normal IgA level. Does anyone know what this tests? If you don't, it's okay. I think you would only really know if you like worked in like gastroenterology or other stuff like that. Yeah, autoimmune disease. Specifically, we really use it for celiac disease in gastroenterology. So that's our big test for celiac. And occasionally you might also see IBD patients be positive for this, because a lot of times you can see IBD patients have concurrent autoimmune conditions. Yeah. So I think I just highlighted on this slide. These are like the big pertinent positives and negatives here from what we have so far in our information. These are the big pertinent positives and negatives for our diagnosis of IBD. So that abdominal pain, those frequent small volume diarrhea, those frequent small volume stools that are consistent with inflammatory diarrhea, and the family history of IBD because it is genetic. Yeah, the oral ulcer, psoriatic plaques, because again, IBD can be related to like have comorbid autoimmune conditions. So like psoriasis, arthritis, stuff like that. Yeah. Yeah. Okay. So this is my differential. I just did a really like focused differential for this one, just to give more time to really hone in on Crohn's and ulcerative colitis. since they're a bit different. So for Crohn's disease, key indicators, right lower quadrant pain, perianal skin tags, which we saw in our patient, vitamin B12 deficiency, family history, elevated CRP. All these things make us really concerned for Crohn's disease specifically, which I'll get into why. Ulcerative colitis is a bit less likely due to this being localized in the right lower quadrant. Ulcerative colitis, I can explain why later, but ulcerative colitis, you would see more like left-sided pain. And also a lack of, I think we had a lack of rectal bleeding, I think in our patient it was more there was blood in the stool, but we weren't seeing like bright red blood per rectum, which you'll see more of in ulcerative colitis, which I can also explain a little bit. Rare presentation of lupus-induced diverticulitis. Sure, you could rule that out, but I think with lupus you would see that like autoimmune test led up, the TTG one, I think. Yeah. And then infectious colitis, less likely due to the chronic nature here, because this is a more chronic, I think it was like 4 weeks or more. And then also the lack of sick contacts and the lack of like recent antibiotics and stuff makes this less likely. So yeah. Okay, so the first thing we want to order here is stool studies. So this is literally, sadly, you do have a patient like poop in a cup, and then you test the poop for this stuff. So you do infectious workup for like parasites, C. diff, you culture the stool for all those things. And then you do the calprotectin and lactoferrin levels, which are really indicative of intestinal inflammation specifically. And then colonoscopy. And you want to do a colonoscopy where you can also see the ileum, which is a part of the small intestine. So that you can really assess. And the big reason you're doing this is to just get a picture and see if it looks inflamed, and then do biopsies, because biopsies is where you can specifically diagnose Crohn's disease or ulcerative colitis is through biopsies of the colon. And then, yeah, cross-sectional imaging as well you can use. So like this is where you can use like MRI or CT to evaluate like, is the small bowel really involved here? Are there complications like fistulas or strictures? And this is specific to Crohn's disease. That's where you'll see fistulas, strictures, small bowel involvement, all that stuff. Can IBD cause inflammation in the small intestines? Crohn's disease can, which I'll go into. Also, like you won't see that with ulcerative colitis. So this is what we expect to see on our test results for Crohn's disease, because our patient has Crohn's disease. So we will see an elevated calprotectin or lactoferrin on the stool studies, and we also see presence of fecal leukocytes, which just means we're shedding leukocytes in our stool. And then colonoscopy, you'll see inflammation and ulceration of the ileum, maybe. You might see patchy colonic, like colon inflammation. A big buzzword for Crohn's is seeing something called granulomas on biopsy, which is really indicative of specifically Crohn's disease. It's just like a marker of this specific type of inflammation. And then imaging. You can also see evidence of small bowel and colonic inflammation, and also those strictures and fistulas that I mentioned. Yeah, gross pathology. Yep. So yeah, another big like buzzword that you'll see is cobblestone mucosa for Crohn's disease. Yeah, you just see like this really long-term prolonged inflammation leads to like this cobblestone appearance. So this is like the mucosa of the colon here. And there's just a fun mnemonic. Medical students love the mnemonics for features of Crohn's disease. So in this case, it's Christmas. So yeah, these are just really indicative things of diagnosing Crohn's disease. Right. So now I'm just gonna spend kind of the rest of this time like really kind of giving you the spiel on inflammatory bowel disease and really telling you the differences between Crohn's disease and ulcerative colitis. So these are the two big types of inflammatory bowel disease. Inflammatory bowel disease is a genetic condition. It really is very heritable and passes down in families. Crohn's disease specifically can infect any part of the gastrointestinal tract, and it's characterized by like patchy inflammation. So you can get it at a bunch of different parts throughout, like, so from your basically from anywhere from your mouth to your anus, you can get patchy parts of this inflammation. So like an oral ulcer or an anal fistula or, colonic inflammation, you can see all of those things. A big characteristic, it likes to involve the terminal ileum, so the end of the small intestine, and then it can cause complications like strictures and fistulas. So you remember our patient was having like that right lower quadrant pain. So that's like really indicative of that like terminal ileum pain, like in this area. Yeah, that's like, I don't know if you guys can you see my cursor? Can you see what I'm like circling here? Yes, great. Yeah. Terminal ileum. So yeah, this is Crohn's disease. You see all these like patchy inflamed parts. And like the rectum doesn't have to be one of the inflamed parts. You might not see any like bright red bleeding, which is like you might see acronyms in medical things of like BR, BPR, which is bright red blood per rectum. Because like the color of blood tells us where it's coming from. So bright red blood coming from the rectum versus like dark blood in stool is coming from further up the GI tract. And then ulcerative colitis is mainly limited to the colon and the rectum usually. But the big thing about ulcerative colitis is it always has to be continuous inflammation. So you're always going to see rectal involvement with ulcerative colitis because it always like starts at the rectum and it can go up like a decent amount, but it's going to be continuous inflammation. Yeah. And then we talked through the symptoms. And you can also get something called extraintestinal manifestations of inflammatory bowel disease. So then you can see arthritis, you can see skin lesions, like rashes, these type of things. There's specific rashes that you see a lot with inflammatory bowel disease. So yeah. And so arthritis, does anyone remember our patient's knee pain? Yeah, that's what I was referring to. And then diagnosis is based on like clinical presentation, and then those endoscopic findings from the colonoscopy, histology, and imaging. And then treatment. We'll talk through it more in depth in a bit, but you really want drugs that get down the inflammation or that suppress the immune system. Biologic drugs have a big role here. Sometimes you might even need surgery to remove like a portion of the damaged colon. Make sure I said everything I wanted to say there. Yeah. Yeah, so just initial management, you want to control symptoms with like first line treatments of anti-inflammatory medications. And you want to do nutritional support and management of any deficiencies like vitamin B12 deficiency. And then like long-term management, you want to start thinking about like what is a good maintenance therapy that you can get your patient on to prevent flare-ups, because you can go into remission with IBD. So like you can be on a medication, or like sometimes even people aren't on a medication and just for some reason they're in remission and just doing okay and not having like active inflammation. So that's like the goal, is to have your patient in remission. Why, from a long-term, like thinking about other diseases or processes that people can get, why would we, aside from like symptoms, why would we want our IBD patients to be in remission as much as possible? Why would we want to like decrease that amount of inflammation? There's a big thing we're trying to prevent here. Adhesions, yes, but that's not the big thing I'm trying to prevent here. Colon cancer, yeah, perfect. People with IBD are at really high risk for colon cancer because, I mean, it makes sense, they're having all this inflammation, and if that's not really like managed, then you really have a high risk of colon cancer in these patients. So actually it's recommended that people with IBD, I think it's recommended that they have colonoscopies every 3 years to monitor for colon cancer. So every 3 years after their diagnosis, I think it's like, yeah, every 2 to 3 years after their diagnosis of IBD, they should be having colonoscopies, which can be really hard on some people. Colonoscopies aren't very fun tests. So yeah, that can be really tough to tell a patient that they have to do a colonoscopy every 3 years. Other long-term management, you want to monitor for any complications, especially with Crohn's disease patients. Fistulas. Do people know what a fistula is? See if anyone says anything. A fistula is basically like a hole connecting two things. So you can get like a fistula, like some people can get like a fistula between like their vagina and their anus, or like their like, you know, it's just a hole between two things, which can leak things and just not be very pleasant. Yeah, abnormal connection between two parts, exactly. And you can also, yeah, get strictures you see with Crohn's disease and stuff like that. Adhesions, like someone said, yeah. And then patient education and support. You want to be telling the patient all of these things and why you're doing these things. Like you want to say you need these colonoscopies this often. One, so we can monitor like your disease process. If you like, a patient should know if they're in remission because of their symptoms, but then you can also verify by doing colonoscopies and biopsies. But then you also want to be monitoring for colon cancer, which is why you're doing those so often. So the pathology of IBD. So this is an immune-mediated inflammatory bowel condition. So our immune system is causing this, and it's also why it's related to a lot of autoimmune conditions. Makes sense that they would be comorbid here. More common, and we see this a lot in white people of Jewish descent, because I mean it makes like it is a genetic condition. So with genetic conditions, you tend to see them strongly in like one specific population, specifically like yeah, in this case, white people of Jewish descent. Usually present in young people is when we see it like present, ages like 15 to 35. And then up to 25% of people with IBD have an affected first degree relative. Causes. We don't fully know all of the causes, but I mean, we know it's genetic. You can also like kind of trigger it, like, or maybe it's becoming more common because of like a Western style diet with high processing, causing more like affecting our colon negatively, gut microbiome alterations. Those are like some theories of like why it's becoming more prevalent. And then signs and symptoms, we discussed those. So Crohn's disease pathology specifically. So chronic immune-related disorder, we believe related to excess immune response to some trigger. So you see transmural inflammation. So this is a really deep inflammation. So the inflammation like into the mucosa for Crohn's disease goes to basically, it goes much deeper than ulcerative colitis does. So it affects a much deeper portion of the mucosa. And it can happen anywhere along the gastrointestinal tract, mouth to anus. Unknown immune response trigger, something's triggering it. And then Th1 cells are releasing these inflammatory cytokines. So how I describe cytokines is they're basically like, imagine a crowd of people that they see something going on and then they go get like all of the other people. That's kind of what cytokines are. So they see something's going on and they bring on the like the big guns, like macrophages and stuff like that. So cytokines are basically like the immune system, like alert system that something's going on. And that causes the inflammatory response. And then, yeah, you can also see fistulas. Someone said, did you say ulcerative colitis was continuous or Crohn's? Ulcerative colitis is continuous. Crohn's has patchy inflammation. Yeah, and with Crohn's, you see like, again, those fistulas, stricture formations, that cobblestone appearance, affects the terminal ileum, all of those things. And if I wasn't clear about that, the terminal ileum is like the last portion of the small intestine that connects to the large intestine. That makes sense. Someone said, yeah, cytokines are the guys yelling the red coats are coming. Exactly. And then comparing this to ulcerative colitis, which I'll go into in a few slides, but ulcerative colitis, just to reiterate, it only affects the colon and the rectum, and you'll see superficial lesions. So it's much more superficial damage compared to Crohn's disease, which goes much deeper into the mucosa. And then, yeah, also an autoimmune disorder, but where the tissue is directly attacked by the immune system. So just continue with Crohn's disease pathology. So we've kind of talked through most of these, but this is the like Crohn's disease is where you'll see like the loss of vitamin B12 and the malabsorption becomes really prevalent because the small intestine is a really big place for like absorption of a lot of our important vitamins and other things, like I think iron and other things like that. So you might see more anemia as well. Up to 20% of cases of Crohn's disease present with inflammatory eye, skin, joint lesions like uveitis, which is an eye inflammation, erythema nodosum, and pyoderma gangrenosum, which are skin conditions. You don't need to know the specifics of these, but it can do lesions in your eyes and your skin and your joints, like arthritis. I included a picture of pyoderma gangrenosum on the leg of an individual with Crohn's disease. So yeah, a really not fun extraintestinal manifestation. You can also see perianal abscesses and also perianal fistulas, which, if you can imagine, are very, very unpleasant for people. I've met a few patients who deal with these as part of their Crohn's disease when I was working in gastroenterology, and they're very not fun. So, and then intestinal obstruction, you'll see in up to 30% of people with Crohn's disease. And intestinal obstruction is like sometimes something that has to be dealt with surgery. So these people really do have to deal with a lot, and it's not a fun disease to have. And I also included a pathology slide. Remember I said granulomas on those biopsies are a big like keyword for Crohn's disease. You see the granuloma whenever like I'm looking at pathology slides on tests. Granulomas are really easy to identify because they're just like those really big circle looking things. So that's a granuloma. And just think of it as a really big pocket of inflammation, like an inflammation hub. Yeah. And then diagnosis of Crohn's disease is made with biopsy. And I mentioned cobblestone appearance, granulomas. You'll see the intermittent lesions. You also see a lot of pseudo polyps, which are like fake polyps, basically, just based on like there's criteria for what makes a polyp versus what makes a fake polyp. But I'm not going to go into that. Someone said, I think, can vitamin deficiencies cause scurvy? Yeah, that's vitamin C. So maybe. But I think vitamin B12 is the big one that doesn't get absorbed well in Crohn's. Yeah. All right. So I'm going to talk through our big treatments here. This is all okay. I think these are all. Okay. So our first line treatments are those anti-inflammatory medications that I talked about. So like I can never say this word, sulfasalazine, which is a type of 5-aminosalicylate, or 5-ASA is what you can call it. So just think 5-ASA are like first line treatments for anti-inflammation for Crohn's. And that just helps really immediately manage those colonic symptoms to get someone feeling more comfortable. But this isn't really like as much of a long-term medication per se. You could also give antibiotics like metronidazole to help with like anti-inflammation and stuff. Immunosuppressants, like when someone's having a flare-up of IBD and their symptoms are really bad, you'll a lot of times see them get a course of prednisone. Usually if they're not responsive to antibiotics well. But prednisone is very effective. Like steroids are very effective in getting that inflammation down quickly. But again, this is not a long-term solution. People can also use antidiarrheals just to manage symptoms like Imodium and stuff. And then another big thing here is like things like biologics, so like anti-TNF agents or things like that. And this is like for moderate to severe disease is when we're going to consider things like biologics. So I'm just going to spend a second kind of talking about biologics because I think they're really interesting. So it's a type of therapy used in the management, like I said, of moderate to severe Crohn's disease and ulcerative colitis, so IBD. They target specific molecules in the immune system that are involved in that inflammatory process that I was talking about, with the overall goal of bringing someone into remission by reducing inflammation and controlling symptoms. So biologics target basically proteins involved in the immune response. So like some biologics target cytokines, like anti-TNF agents. They can also target other proteins that play a role. And by blocking those proteins, biologics help to reduce inflammation and bring patients into remission. So you'll see things like a big one is infliximab, brand name Remicade, which is an anti-TNF agent, which is a biologic, which you see a lot. Also, if people have seen the ads for Humira, which is adalimumab is the generic name of that. And for someone said, how would you manage an older patient with a lot of other issues like prednisone allergy and late-stage renal failure, which might make NSAIDs a poor option? With that, I think if they have moderate to severe disease, I think a biologic would be a really good option. You see people tolerate these really well for the most part. You can also see anti-integrin agents. That's another type of biologic. Like if anyone's heard of Entyvio, that's an anti-integrin agent, which is just another protein in the inflammatory response. And then you also see things called IL-12 or IL-23 inhibitors. Like if anyone has heard of Stelara, that's another one. You see a lot of ads for these. So like IL-12 and IL-23 are also involved in the immune response and can help with remission. So I think a big thing with biologics when helping patients with biologic therapies is, and what's really important to a lot of patients when picking one, because they're all like pretty effective, is the frequency of the dosing and if it's an infusion or an injection. I believe that Humira and Simponi, which are anti-TNF agents, they are injections, so people can do them at home every so often. So some people prefer that because otherwise you have to do an infusion for the rest of these, I think, except for Stelara. I think Stelara is also an injection. But for the infusions, you basically come into like your gastroenterology office every like few weeks, like I think it's like 6 weeks or something, 6 to 8 weeks, I think. And then you just kind of sit there for a while, like a few hours, while something is infused into your body, basically. So some people don't mind because you do it every like 8 weeks once, and you just chill and read a book and then it's done. Some people don't want to have to come into the office, especially if they have busy schedules, so they'll do an injection at home. Some people don't like injecting themselves. So these are like things that you make a plan with the patient of like what's going to work best for them. Yeah, so it's things like that we talked through, like first line versus second line therapy, long-term therapies. Biologics have been shown to be highly effective in maintaining remission for Crohn's disease and ulcerative colitis, but the response can vary among patients. So I've seen patients in gastroenterology where one biologic just isn't bringing someone into remission, you're not seeing improvement, so then they'll switch you to another biologic and just try something new. So you'll see like some switching if something after a certain amount of weeks like isn't making a difference. So it's something where you really want to tailor it to the specific patient, which can make gastroenterology a really kind of fun area to work in, because it really is like you're really partnering with patients, especially your IBD patients, and really helping them like make a plan for the management of their disease that works for them. So yeah. And then monitoring, you just want to monitor, assess response, monitor for side effects, because you can get some side effects with these, but in my experience, it seems like most people tolerated them okay. And then adjust treatment as needed. Yep. Sorry, there's a big spiel on biologics, but I find them very interesting. I'll kind of go through the rest of this quicker. So yeah, ulcerative colitis pathology, superficial ulcer formation. We kind of talked through most of that. It's the more common inflammatory bowel disease compared to Crohn's. This involves CD8 cell activation specifically. So you basically, one type of your immune cells is destroying the cells in your submucosal layers, basically. The CD8 cells are called the killer cells of your immune system. Basically, it's attacking stuff it's not supposed to. More common among white people of Eastern European descent. More common in young individuals who are biologically female. Causes, again, unclear. Autoimmune reaction against colonic flora. Yeah. We don't know specifically. Environmental factors may contribute to like flare-ups. Yeah, so just a little bit of differences in like some of the symptoms. So you'll get like left lower quadrant pain, specifically, like because we talked about is more likely to be continuous from the rectum. So if people know the biology of like your large intestine, like the descending colon is on the left side, which is the one most closely related to your rectum. So yeah. And then yeah, diarrhea, you'll see more like grossly bloody stools, like bright red blood, more blood in ulcerative colitis. That's also a big indicator. Yeah, all those other symptoms we talked about. Yeah. And then the big biopsy thing here for ulcerative colitis is crypt abscesses, which I showed an example of. You learn a lot of like buzzwords for pathology stuff in med school, so like you just kind of have to associate them in your head. And very similar like treatments. I don't really have to go into that again. Oh, I forgot to talk about surgery though, so I'll do that really quickly. Sometimes with treatment you have to do surgery and remove the affected tissue. Sadly, you see a really high relapse rate after, and then you can also get short bowel syndrome, which is a complication of like having too short of a bowel after taking out parts of it. You get problems with malnutrition and other stuff like that. Yeah, risk factors for IBD, multifaceted triggering factors. Yeah, It's like an intersection of genetic predisposition, possible environmental influences, immune system dysregulation, gut microbiome, that kind of stuff. Yeah. Interesting thing with smoking is with smoking, Crohn's disease is believed to be like a risk factor for Crohn's disease is believed to be smoking, but weirdly with ulcerative colitis, you actually see a decrease in ulcerative colitis in smokers. So don't know why. And then prevention. You sadly, like, this is something with a big genetic component and it doesn't have a cure, it just has remission. So sorry, I'm trying to move this thing so I can see my slide. There we go. No known cure, exact cause remains unclear, but there are no guaranteed ways to like prevent this, but you can try to mitigate symptoms as best you can through finding the best treatment for you. Like if you have Crohn's, quit smoking, exercise regularly, as that can help maintain a healthy weight, which is helpful for reducing flare-ups, like just in decreasing the amount of inflammation in your body and stuff like that. Balanced diet. Yeah, basically things trying to bring down the amount of inflammation in your body. Yeah. And then really quickly, complications. A big complication is basically something called toxic megacolon, which is a severe complication of either IBD or infectious things like C. diff. It's characterized by basically your colon just dilates a ton. Like if you guys see in this picture, look how large that colon is. I don't know if other people have seen x-rays, but that is a huge colon. Like the circumference, like width of that is huge. So you just get systemic toxicity from that. So like you get really bad inflammation, peristalsis, which moves stuff to the colon, isn't working. So stuff just piles up and becomes toxic, and you get inflammation. You can get risks of colon perforation, septic shock. So with this, what you're really worried about, like the symptoms you'll get really worried about this with is like very severe abdominal pain and distension, like fever, severe, like basically severe pain, fever, abnormal vitals like tachycardia or hypotension, and then like bloody diarrhea. But you also see decreased bowel movements with this because stuff is getting caught up. So that makes sense. And then you want to diagnose like distended tender abdomen, this x-ray that I'm showing, and then those labs that we look at. And then you want to manage with something called bowel rest, which means you're just giving like liquids, like IV fluids, antibiotics, treat with corticosteroids to get that inflammation down. And then you might even need a colectomy if you don't see improvement because you're really worried about perforation, as that can cause like really systemic problems. Yeah, not good. And then some of my sources, and that's it. So any questions for me? I'll stay on for like the next few minutes for people to have questions. Yeah. Big told many diseases such as gluten, yeah, celiac, since wheat is made more processed, I definitely think there's probably an association, but it's hard to like know in the scheme of things, like, are things becoming more prevalent because of the environment, or is it kind of confounded by also, are we just diagnosing things better and having better health care, or people like living longer, those kinds of things. So it's hard to know with like prevalence as much, but I'm sure like if you got rid of all the confounders, I still think there would be an increase because of like our diet. And I think our diet is very pro-inflammatory, which causes or triggers a lot of these things. Thank you guys. How are hemorrhoids different from rectum inflammation, from IBD, Crohn's? So hemorrhoids, like I like to say everybody has hemorrhoids. It's just if they get like it's basically just blood vessels around your anus. And with hemorrhoids, it's just like if they get irritated, basically. So it's just like an irritation of blood vessels you already have. Whereas like the bleeding that you see from like IBD is like your colon mucosa is inflamed and not working correctly, and that's causing bleeding. So that's kind of the difference. In the case of IBD, would you recommend increased fiber intake or supplementation? With fiber, I think fiber is kind of like, it can help with both diarrhea and constipation, and that like with diarrhea, it can help like bulk up your stools versus like with constipation, it can just help with like sometimes the bulking up of that with constipation can weirdly sometimes help with the fiber as long as you don't like bulk it up too much and do too much fiber too fast. It can like make you more regular, if that makes sense. Um, but yeah, so I'm sure it would like help with like the diarrhea symptoms, but like the main thing is you want to put someone into remission by decreasing the inflammation. So that would be the big thing you would be worried about.